Hello, everyone, and welcome to Meaningful Use, Gearing Up for Stage 2. This webcast features noted healthcare expert Elizabeth Woodcock, and is sponsored by Intuit Health, the leader in patient-to-provider communications. Today, the Intuit Health Patient Portal helps more than 5 million patients and tens of thousands of providers to easily and securely communicate online. The portal helps providers save time and makes it easy for patients to pre-register, complete medical forms, request appointments, and refill prescriptions. The portal makes understanding and paying bills, receiving lab results and clinical summaries, and exchanging messages for related care and administrative issues simple and convenient. Intuit Health is part of the MGMA Administer program, an exclusive group of pre-screened, peer-reviewed, and tested vendors, and also an AAFP Advantage program partner for patient-centered medical home. As you'll discover today, patient portals are becoming even more important with the proposed changes to meaningful use, and our goal today is to help you understand more about how these changes will impact your practice in the coming months. You can find out more information about Intuit Health and the patient portal at www.intuithealth.com. My name is Chris Repetto, and I'm the Communications Director for Intuit Health. I'll be your moderator for today's session, and I'll introduce our speaker in a minute. But first, allow me to take care of some housekeeping items and orient those of you who are new to the On24 console. Today's presentation will run a little under an hour, and we'll have about 15 minutes at the end for questions and answers. You may submit a question at any time during the presentation. Simply type your question into the Q&A box on your screen and click the Submit button. If you don't see the Q&A box, just click the red widget with the QA on it at the bottom of the screen. Elizabeth will answer as many questions as she can today, but if we run out of time, don't worry. We'll be sure to follow up with you individually and make sure that you get your questions answered. Slides from today's session, in addition to the handout on the proposed Meaningful Use Stage 2 objectives and information about Intuit Health, are available in the Resource List widget at the bottom of your console. That's the green button with the open folder. And shortly following the broadcast, a recorded version of today's webinar will be made available to all attendees. Now, we understand that we're a little bit ahead of the final ruling for Stage 2, so later this summer, after the release of the final ruling, Elizabeth will be writing a white paper detailing this information, and we'll be sure to make this information available to you. Please keep in mind that this webinar will be focused on Meaningful Use Stage 2 and assumes a base level of understanding of Stage 1. If you'd like to view our webinar from last June that focused on Stage 1, you can click on the URL in the Resource List widget at the bottom of your console to view it on demand anytime. There are also additional widgets like email a friend or share this, and we encourage you to let your friends and colleagues know about this webinar if you feel that they would benefit from the presentation. And lastly, also across the bottom of your screen, you'll see a widget specifically for Twitter, and we encourage you to share your thoughts during today's sessions and afterwards, and please use the hashtag or number sign. It'll be number sign Intuit Health MU2, and that's all one word. So INTUITHEALTH MU2, all one word with a number sign in front of it. And while you're at it, why not follow Intuit Health on Twitter or like us on Facebook so you can stay up to date and engage with us on those social channels. So now, without further ado, let me introduce our speaker today. We're very honored to have Elizabeth Woodcock with us today. Elizabeth is a best-selling author, trainer, and professional speaker specializing in medical practice management. She's authored 10 books on practice management, most notably Mastering Patient Flow to Increase Efficiency and Earnings. She's a fellow in the American College of Medical Practice Executives and a certified professional coder. Elizabeth earned a Bachelor of Arts degree from Duke University and also holds an MBA in Healthcare Management from the Wharton School of Business at the University of Pennsylvania. Intuit Health has worked with Elizabeth many times before, and the feedback from her webinars has always been extremely positive. We especially received rave reviews from her June webinar that I mentioned earlier that covered Stage 1 meaningful use and focused on how portals improve workflows and keep patients loyal. In fact, after that session, many of the audience comments requested we hold a similar session on Stage 2 when the timing was right, and based on the amazing turnout for today's discussion, it appears that this topic is very important to you, so we're happy to offer it up for you. So backed by popular demand, Elizabeth is here with us today to walk us through Meaningful Use Stage 2. So ladies and gentlemen, here's Elizabeth Woodcock.
Thank you so much, Chris, and especially thank you to our sponsor today, Intuit Health. I am certainly delighted to have the opportunity to speak with you all today regarding this highly anticipated release by the government of the proposed Stage 2 requirements for the EHR, Electronic Health Record Incentive Program. Although the program was actually initiated in 2009, it continues to be a priority for our industry as many healthcare professionals, physicians, providers contemplate and embrace technology. Meaningful use continues to be a driver of automation in our industry. Indeed, some of you may have seen a poll just published in a recent issue of Medical Economics reveals that the majority of adoptees of electronic health records were driven by the government's EHR incentive program. So with a packed agenda about this newly released rule, let's go ahead and get started. Our agenda today is to briefly review the background of the program. As Chris mentioned, we're assuming that you have at least a working knowledge of, indeed, meaningful use. Next, we'll summarize the changes to Stage 1. You heard me. There actually are changes to Stage 1 which were included in the proposal regarding the new Stage 2 criteria. So we want to make sure you know about those. Then we're going to overview the proposed Stage 2 criteria, giving you a particular focus on the 4 new patient and family engagement criteria, which are 4 of the new 22 criteria being proposed for Stage 2. Then we're going to acknowledge the value of a patient portal as it relates to meaningful use. And then finally, we'll conclude with a Q&A session. Importantly, I did want to make note that this presentation is focused on eligible professionals. We're actually not going to be discussing the proposed criteria for eligible hospitals and or critical access hospitals. Furthermore, you're going to note the term proposal. The webinar today presents the government's proposal. The government is planning to finalize the criteria for Stage 2 this summer. Despite the fact, however, that the material we're going to be addressing today is only a proposal, I would submit to you that past proposals, while they have incorporated changes, have had a distinct relation to the actual proposals. So in sum, while this may not be the final ruling, we're expecting it in July of this year, it's going to certainly provide a clear window into what we should expect for the next segment of our industry's journey, and it's a wonderful one, to meaningful use. Now, from a background perspective, the journey to meaningful use began in February 2009. And this began with President Obama's signature on the American Recovery and Reinvestment Act, or ARRA. The piece of legislation, which was signed into law in February, right after Obama stepped into office, is also referred to as the stimulus package. It brought us programs like Cash for Clunkers, for example. But it also ushered in, very importantly, an incentive payment for automation in the healthcare industry. Soon given the official title of the EHR Incentive Program, eligible healthcare professionals are paid between $44,000 and $63,750 for demonstrating the meaningful use of a certified electronic health record system. Because the government wanted the industry to go from, ground zero, barely any technological adoption, to full electronic integration, the program was actually structured to be laid out in 3 different stages. So Stage 1 began in 2011. Indeed, the registration was accepted January 3rd, and attestations were accepted in mid-April of 2011. And early adopters were actually expected to be prepared to embrace Stage 2 in 2013. But late last fall, the government said, hold the phones. We're not ready to announce stage 2, and so they announced in November a delay of stage 2. We know now that stage 2 will begin in 2014, and the proposed criteria that define stage 2 were the ones just announced, the subject of our webinar, just announced in March in the Federal Register. It's this announcement that forms the basis of our program today. Now, in the Federal Register, which this issue is authored by the Centers for Medicare and Medicaid Services, the government confirmed that stage 2 will begin in 2014. And although our focus really is on the stage 2 meaningful use criteria, it's important for all of us to recognize that on the very same day that CMS released its proposal in the Federal Register, a separate government agency, indeed the Office of the National Coordinator for Healthcare Information Technology, released a separate proposal in another volume of the Federal Register released on the very same day, titled, get ready for this, it's a mouthful, Health Information Technology Standards, Implementation Specifications, and Certification Criteria for Electronic Health Record Technology 2014 edition. The ONC defines the criteria for certified EHR technology for stage 2. So I think it's important to recognize that as you listen to the new criteria, you may say, oh my gosh, I've been doing stage 1 meaningful use, or at least I've been reading about it, and I don't think my current certified system can even meet the proposed definitions that you're outlining. Critical to recognize that your EHR system, at least your vendor, in order to retain its official certification, will be required to deliver you the capability to meet these new criteria. So if you will, there's an aligned Federal Register for vendors regarding meaningful use and the system capability. Now back to our proposed rule, the CMS rule, which of course is several hundred pages, a little light reading if you're interested. There are actually several key areas of focus. The first 3 items, interestingly enough, actually have nothing to do with stage 2. In fact, it's critical to recognize that the government is actually using this opportunity to propose changes to the criteria for stage 1, as well as to refine the definition of the Medicaid patient volume, which is really at the core to being eligible for the larger amount of bonus, the $63,750, as well as the CMS announcement in the Federal Register finalizes the Medicare payment adjustments, finalizes those payment adjustments. It also fully outlines its proposed criteria for stage 2 meaningful use. Now, you still actually have about a week to make any comments that you might have on the proposal. As noted previously that I mentioned, please recognize that these are indeed proposed regulations. The final rule is expected to be released in July of this year. So let's go ahead and first take a look at some of these proposed changes to stage 1 that I just mentioned. Computerized physician order entry, I would argue one of the hallmarks of meaningful use, is being altered. It's slight, but it's being altered. The current measure includes the number of unique patients with at least one medication in their medication list seen by the eligible professional, and that indeed is defined as the denominator. The government announced there was a lot of confusion about this. They certainly didn't wish for that confusion, and so to simplify the measure, the government is proposing to change the denominator to be very logical, the number of orders for medications. Now, like several of these changes that we're going to talk about and others that are included indeed in the proposal, these changes are actually going to be optional in 2013. And I think this is very important for all of us who are looking at the Meaningful Use program, is to recognize that we're just a few short months from indeed using some of these changes as an alternative, at least for 2013, but recognizing they may be required in 2014. Now, one of the most controversial aspects of meaningful use, ironically, it seems kind of basic, but vital signs, the recording and charting of changes in patients' vital signs. And I say controversial because there's a lot of challenges from specialists and even primary care physicians that are saying, all of these required. But indeed, while avoiding the aspects of that controversy, there is going to be a proposed change. And the proposal, I think, will actually reduce some of the controversy in that it is splitting the exclusion. So you can indeed split. To split the exclusion, you can exclude yourself on the basis of clinical relevance. And so now we can say, you know what, okay, I can do blood pressure, but you know what, height and weight indeed is part of my clinical relevance exclusion. So in addition to splitting those up, the proposal actually increases the age limitation for patients for a blood pressure from 2 years of age to 3 years of age. And this is indeed aligned with the American Academy of Pediatrics and others that were a proponent of these changes. The changes will be optional in 2013 and required in 2014. Describing this objective, the capability to exchange key clinical information. It's one of our core Stage 1 criteria. CMS uses the term surprisingly difficult for providers to understand. Surprisingly difficult for providers to understand. The government is just completely proposing to eliminate this criteria altogether. So interestingly enough, if you've been looking at 2013 and you're gearing up for Stage 1 only because you're a little bit, wanted to do this in its third year, so you're in Stage 1 for next year, just be sure you're aware. You want to really pay attention to the July announcement to make sure, do I even have to comply with this criteria? The government is proposing that you will not. Given the challenges that eligible professionals have had regarding the fulfillment of this criteria, and I say this, there are actually two public health-related criteria that are on the menu. Now, they're on the menu, but as many of you know, when you look at the 10 menu items, you are required to choose one of the two public health-related criteria. And these criteria include submitting immunization data to a registry. Now, the government has acknowledged that some eligible professionals are actually prohibited from submitting the data, or even more importantly, the registry actually only accepts certain data or perhaps doesn't accept it at all. So the government wanted to make the point that the data need only be submitted except where it is prohibited from being accepted. So again, the except where prohibited will be required as a clarification, if you will, in 2013. I briefly mentioned we're seeing changes to, indeed, the calculation of Medicaid patient volume. This is a critical aspect of achieving the minimum volume that is required to participate in this program. And that minimum volume, of course, is 30% for adults providers, 20% for pediatricians, and the government is actually proposing to allow all Title 23 funded encounters, including CHIP, to count as a quote-unquote Medicaid encounter. The other interesting proposal is to allow the previous 12 months prior to the attestation to formulate the reporting period to qualify for this 30 or 20% instead of the prior calendar year, which was proposed and is actually the current regulation regarding meaningful use. Now, this is actually going to be a significant improvement for new professionals in particular, because today they really had to wait for a full calendar year. Okay, let me get my 90 consecutive days that I'm measuring my 30 or 20% patient volume in Medicaid, and now we actually just simply have to use the prior 12 months in terms of advance of the attestation. So this is great news if accepted for new eligible professionals. Now, the government did confirm, I'm going to use the term unfortunately, because I know many of us were kind of hoping this might have changed, but indeed the government confirmed that the so-called payment adjustments, and I love this because it's the government's like positive spin, if you will, on the term penalty. I mean, you look through their website, you will not find the word penalty associated with this quote-unquote voluntary program. Indeed, it's not mandatory to participate, but if you choose not to participate, you will receive a payment adjustment. And that payment adjustment will begin in 2015. Now, the first year penalty is 1%, and that's going to, of course, be applied to Medicare reimbursement. It will increase by 1% each year up until 5%. And this is actually at the discretion of the Secretary of Health and Human Services. Now, I think most importantly, many of you are saying, okay, we knew that, but how can it be avoided? Well, what this Stage 2 proposal, indeed the Federal Register states, is that you can avoid the penalty if you are ineligible for the program. So if you're a hospital-based professional and you are not eligible for the program, you won't be penalized via this Medicare reimbursement reduction. Now, if you are eligible for the program, you can actually avoid the penalty by successfully participating next year. In 2013, or at the very minimum, you've got to get your attestation in by October 1st of 2014. That's like the drop dead date. Now, I am certainly not going to recommend that you wait for that last 90-day period and you're logging on to the internet, indeed, late in the night, the last day of September. You're just absolutely nuts. But the government says you got to get it in by October 1st. But I want, of course, you to allow yourself some more time. Now, alternatively, the government is proposing, and this is very important because it is indeed only a proposal, for exemptions, lack of internet availability, new professionals, unforeseen circumstances, maybe like indeed a hurricane. They use the term natural disasters in the Federal Register. And then there's sort of an interesting, almost kind of nebulous criteria, and there's some discussion about this indeed in the Federal Register, that there is consideration for an exemption regarding limited interaction. These are eligible professionals with limited interactions with patients or lack of control of access to an electronic health record. So we'll kind of have to keep our eye on that to see what the government does with this fourth and, again, it's almost sort of nebulous criteria for the exemption. Now, I just wanted to make note that there are absolutely no penalties no penalties at all associated with Medicaid. These reimbursement reductions, the so-called payment adjustments, will be exclusively on the Medicare side. So we've got to move to stage 2 because that's why we're all here. So in addition to announcing these fairly, I would argue, important changes to stage 1 that I just overview, the government revealed its intention to maintain the structure, core, and menu criteria that's currently in place for stage 1, and they're indeed going to maintain that for stage 2. Instead of the current 25 criteria that we have today in stage 1, stage 2, the plan at least, is to consist of 22 criteria. Now, you'll see, though, very quickly that instead of 15 being required, 17 will be required. Those are the core criteria, and there's going to be 5 on the menu, of which you'll need to choose 3. And, of course, this is very different than our menu today of 10, of which we need to choose half or 5. The government did make a point of indicating that will include exclusions, just like we have today, to the criteria. But there's a lot of discussion in the Federal Register that indeed professionals cannot use them to disqualify themselves from the criteria. So like today, you probably notice in stage 1, you can kind of look at the menu and say, you know what, I am totally exempt. I can't do that. I fall within the exclusion. I'm going to choose that as one of my menu-based criteria and call myself exempt. The government's not going to quite give us, or at least that's what they're alluding to, that much leeway. Professionals, again, cannot use the exemptions to disqualify themselves from the criteria. In stage 1, we've got 6 clinical quality measures. Indeed, this requirement is actually going to double to 12, although there is significant amount of discussion. I would say, like, gosh, a quarter of the entire Federal Register is dedicated to CQMs and how those 12 will indeed be chosen. So in summary, we're going to retain, the government is, the core menu structure, double the required number of CQMs, but in addition to this kind of overview, if you will, stage 2 completely removes one objective, that capability to exchange key clinical information. And that's actually being proposed, as we just noted, to be eliminated from stage 1 as well. Now, this is where I find it very interesting, because instead of replacing the criteria one-to-one, stage 2 actually says, okay, we're going to combine several stage 1 objectives to create a single one new criteria for stage 2. So while you might think, well, basically, we're going from what? 15 to 17, ain't no thing. We got 2 more we need to do. What I'm suggesting you, as you will see in just a few minutes, is that they're actually a lot more than 17, because there's almost like Part A and Part Bs, of which you've got to do A and B. As expected, in addition to more criteria, there are higher thresholds for the measure. So instead of, for example, 30% of a criteria being required, that number is now moved to 50%, for example. And finally, and perhaps most importantly, as I mentioned, there's a huge amount of real estate, if you will, that indeed the government uses for CQMs in the Federal Register, that there is such a significant prioritization of clinical quality measures that the government has actually moved CQMs out of the criteria to specifically state that, you know what, CQMs are meaningful use. They are so important. They're not even one of the criteria. They are meaningful use. So as I noted, the government is proposing these 12 CQMs for stage 2. There's a significant amount of discussion regarding how they'll be chosen. There's, for example, an option to outline some clinical domains. And in fact, you can read about them, the domains, if you will, in the Federal Register. And the proposal is to require that one CQM will be required from each domain. Now, the government does outline several scenarios in terms of how CQMs must be chosen, but it makes it very clear that thankfully, it will accept electronic submission of the CQMs and, bless the government for this one, that the program, the EHR incentive program, will finally be aligned with PQRS, the Physician Quality Reporting System, Medicare Shared Savings Program, and even, as proposed, the NCQA certification for patient-centered medical homes. So we are very, very excited about this new alignment. Now, as you go through the criteria, and indeed you will find that all of the criteria are provided as a supplement to your handouts, you may say, well, okay, stage 2, it's not that much of a step up, if you will, from stage 1. But there is one, at least in my opinion, distinct difference. Several of the criteria, and we're actually going to go over them, actually require action on the part of the patient. The patient's active involvement, this is a significant change from stage 1, which really focus more on patient engagement. Now, CMS blatantly recognizes this modification and makes the statement in the Federal Register, and it's displayed for you on the slide. This is a departure from meaningful use measures. Requiring a measurement of patient use ensures that professionals promote the availability and active use of electronic health information by the patient. Accountable care. Have we heard those words before? Accountable care should encourage patient and family involvement. I got to tell you, folks, my takeaway from stage 2, this proposed rule, we are seeing the migration from patient engagement to patient action. Now, let's go ahead and really dig down deep into what I'm talking about and review in depth 4 of the 22 proposed criteria for stage 2. Now, these 4 are going to be the criteria, not just focused on patient engagement, but no, we're stepping it up a notch. We're focused on patient action. Now, what I'm going to do is give you, if you will, the stage 1 measure that is essentially being replaced by the stage 2 proposed measure. And here, indeed, is the first one. As you well know, because many of you are complying with this right now in stage 1 of meaningful use, there is a measure, a core measure to provide clinical summaries to patients within 3 business days, and this has to be done for more than 50% of office visits. All right, so the measure in stage 2 is being replaced by the new criterion to provide clinical summaries within 24 hours. Now, these after-visit summaries can still be satisfied with paper, provided to the patient as they leave the office. But the government says regardless of the method, they must be provided within 24 hours, indeed, instead of 3 business days. So that's a good example of kind of the government, maybe keeping the core, if you will, of the measure, but changing the bar, moving the bar up. CMS also states in the Federal Register an eligible professional can choose whether to offer the summary electronically or on paper by default, but, and it's a big but, must make the other form available at the patient's request. Now, in addition, for this same criteria to the patient's name, problem list, procedures, test results, etc., the information for stage 2 must include a care plan field. What exactly is a care plan? Well, the government defines a care plan as, and I'm quoting here, the structure used to define the management actions for the various conditions, problems, or issues. In addition to the actual problem, which is really the focus of the care plan, the government says, you know what, in stage 2, this plan must also identify the goals and the instructions provided to the patient. So we saw a slight alteration in the measure. We saw raising the bar, but importantly, we also saw a distinction in the actual criteria itself. So our second patient action is sending reminders to more than 20% of patients who are older than 65 or younger than 5 for preventive follow-up care. Now, this criterion for stage 1 is actually on the menu, is going to be replaced by a new measure on the core side of stage 2, and you'll see that, well, hold on, we've gone from 20% down to 10%. That's the exact opposite of what Elizabeth just said. I mean, I thought the bar was supposed to be raised higher. But you got to look carefully, because you will notice that the criterion is now part of the core criteria, and it includes all active patients, or at least those seen within the last 24 months. Now, our third patient action criteria, if you will, replaces 2, count them 2, stage 1 criteria. One's going to be from the core, and this is providing patients with an electronic copy of their health information. And the second one is actually from the menu, and that is a very closely aligned criteria providing patients timely electronic access to their health information. Now, this is a good example of a 2-part measure. Okay, and you can't choose A and, win and get it. You've got to actually have both A and B successfully performed in order to satisfy the criteria. Indeed, more than 50% of patients are provided timely access to their health information, and more than 10% of patients, your patients, view, download, or transmit the health information to a third party. Okay, let's just step back right here and say, folks, this is where we're really seeing the government get serious about patient access. You got to read this 15 times like I did and say, whoa, whoa, whoa. The proposal is to require that your patients, well, at least 10% of them, access their health information. So it's not good enough to just provide the information. You actually, in this criteria, must prove that a portion of your patients accessed it. This is a big difference from stage 1. So how can the access be accomplished? The government clearly states, and this is a quote from the Federal Register, the patient must be able to access this information on demand, such as through a patient portal or a personal health record. Now, in further clarification, the government notes that the eligible professional can host a patient portal, contract with a vendor to host a portal, connect with an online personal health record, or other means. Now, while it was adequate in stage 1 to give a patient a CD-ROM or a thumb drive, and I say adequate, we could do so by regulation. From a workflow logistical perspective, I think handing out a bunch of thumb drives at checkout, like just makes my head spin. But you could do it to fulfill the electronic access requirement. But this time around, in stage 2, the government is actually expressingly forbidding this. They're actually stating that the relocation of electronic media does not qualify as a transmission to fulfill this criteria. Now, importantly, there is an exclusion to this measure. So indeed, as we know from stage 1, there's exclusions to a number of the measures, in fact 13 of the 25, and indeed in stage 2, that same type of core and menu and exclusion will indeed be in place. Now, if the professional doesn't create health information, he or she would be exempt. I guess I find it a little bit hard to figure out how you would be a healthcare professional if you don't create any health information, but I don't think that's really for me to decide. But if you don't, you're exempt. This is perhaps more important if the professional practices in a community that has an infrastructure that's inadequate in terms of, if you will, data transfer speed, then indeed the professional will be exempt. Now, I also wanted to note that this really isn't an exclusion per se, but the government makes it very clear in the Federal Register that it defers to the eligible professional's judgment as to whether to hold information back in anticipation of an actual encounter or a conversation between the provider or a member of their staff and the patient. Now, just as we saw in stage 1, the information doesn't have to be released by the eligible professional if he or she believes that it will cause substantial harm to the patient. So that's certainly consistent with what we have in stage 1. Now, just like we saw in the first patient action-oriented criteria, the government is altering the definition, not just the criteria, but okay, what information needs to be encompassed, included in the health information that we've got to make available to patients electronically. Consistent with that first criteria, health information must include the care plan for the patient. It also must include any additional known care team members beyond the referring or transitioning provider, as well as the receiving provider. Now, indeed, you may say, whoa. I mean, my system can't do this. I don't have like care plan. What am I going to do? Now, I'm going to take you back to the beginning of the program, and remember we said there is a whole nother Federal Register that the Office of the National Coordinator for Healthcare Information Technology has released on the very same day that essentially is geared towards the vendors, and it's saying, okay, vendors, you've got to have your systems give eligible professionals, the capacity to carry out, the capability to carry out all of these stage 2 criteria. So let's talk about our final patient action-oriented criterion, talk about patient action. The next criteria, which is being proposed as a core, not a menu, a core criteria, is the use of secure electronic messaging. Indeed, you are reading this correctly. The government is actually requiring that 10% of your patients send you a message. Hello. Indeed, this requires not that you send the message, but that the patient actually initiates one. Now, once you've come to your senses after hearing this, you say, okay, but what about the response? CMS specifically states, and this is a quote, "We note that there is an expectation that the eligible professional would respond to electronic messages sent by the patient. although we do not specify the method of response or require the eligible professional to document his or her response as a condition of meeting this measure, end quote. I have to say, I literally erupted in laughter when I was reading the Federal Register, and it's a very dry document. I love this response because it's so unbelievably unrealistic. Of course, from a medical legal perspective, once you get these messages, hello, you're certainly going to have to document them as well as respond to them. Now, we've just had enough time to review 4 of the proposed 22 criteria, but I really wanted to point out that I actually took the Federal Register and I typed up all 22 of the criteria, both the measure and the objective. So that is going to be provided for you. You will find those in an appendix that you can download, take a look at on your leisure time, recognize it is a proposal. You will find the source if you do want to read the Federal Register yourself, and there's a lot of great discussion in it. A lot of great discussion that certainly is going to be included at the bottom of those handouts. Now, after you've had a chance to digest the proposed Stage 2 criteria, I've got to tell you, it doesn't take a rocket scientist to recognize that the government is pushing patient and family engagement. Indeed, even if the rules do change between now and July, the proposal certainly makes us sit back and realize that the government intends to make good on its goal of extending technology far beyond the walls of the practice. And interestingly enough, even beyond the walls of the health system, the information exchange, if you will. Now we're hit with the fact that the government intends for that information exchange to be extended into the homes of patients. Now, in the meantime, I would argue patients, I know I certainly am, are clamoring for improved access to their physicians' offices. So meaningful use or not, changes to the proposed rules for not, our patients are hungering for self-service. Now, we could spend a huge amount of time questioning, debating, and I'm certainly spending a lot of that time myself doing this, but we can really go in and look at the government's methodology. But I got to tell you, I really would recommend taking this momentum that we have related to meaningful use, where we've really seen patient engagement and the new proposed rules that are really focused on patient action. And we use this momentum to turn this challenge, which it certainly is, into an opportunity for the practice. Now, we know that study after study, and I know as busy professionals, you're in the same boat, a variety of aspects of the practice patients really want. They really want improved communication and enhanced access to the practice. Now, indeed, the government's change of strategy, as well as our patients' seemingly insatiable desire for better access, can this actually prove valuable to your practice? Well, how? And you may certainly ask, what in the world does a photograph of a salad bar sitting on my screen have anything to do with our discussion today about meaningful use in Stage 2? Has Elizabeth gone completely insane? Probably I have. But actually, in this case, anything but. Let's think about this. You walk into a restaurant. Ruby Tuesdays, I know about y'all, but I'm certainly a big fan. Walk in for lunch, you're busy, you don't have a lot of time. Instead of waiting even longer at your table for your food, the restaurant makes it incredibly easy and fast to get food. And actually, through this salad bar, accommodates your needs by offering you both the variety and the quantity you want, just so it fits on that plate, of course. When you walk out a happy customer because you've indeed eaten quickly, efficiently, and you've gotten what you wanted in terms of your choice, I got to tell you, the manager of that restaurant has an even bigger smile on his or her face. Because you know what they've done? What they've done is taken you, a paying customer, and they've made me my own waitress, and hold the phone because we've actually even tipped our waitress too. Now, this notion of self-service can be seen in a lot of aspects of our lives. ATMs. I myself was at the bank yesterday, and you know what I did? I looked at the teller line. I'm like, hello. I'm crossing right back outside, walked right out of the door, and used the ATM instead. Vending machine DVDs, there's a ton of aspects of self-service, and while not the same idea, not the exact same idea unless you wanted to indeed put a salad bar in your waiting room, which might be an interesting thought, but we can take our lowest cost employee. In fact, an employee who is totally free, and we can take that employee and ask them to work for us and be happy, be satisfied while doing so. Now, of course, you probably guess I'm referring to our patient, and although I wouldn't expect for them to tip you, indeed it may be that self-service technology like a portal can be the key to turning your challenge into this opportunity. Communication can improve. Think, for example, of like handling a prescription renewal request via a portal, a patient portal instead of a telephone. The telephone requires synchronous communication. This drives everybody crazy because not only does the patient have to be on the line, but you have to be on the line in the exact same time. Patient portals, on the other hand, require none of that. So instead of paying like Susie to answer the phone and then Sally to take a message, and then Joy to take the message, process it, record the renewal, document it in your system. And this doesn't have to be a paper record, folks. I mean, this is a electronic health record as well. And then we've got Steve who's calling the patient back, and now he's calling him back again and again because he's playing phone tag. And meanwhile, Susie and Sally are taking messages and answering the phones again in a portal. The patient actually takes his or her own message. Think about this. Takes his or her own message, finds his or her own identification. Okay, so we don't have to go, what's your date of birth, what's your ID, blah, blah, blah. Takes the message, finds the communication, finds the identification, and seamlessly transmit it to you to process conveniently between other tasks, and allows a quick message that the prescription is now ready. So this entire transaction, which is documented in the patient's record, has just taken what is 13 or 14 steps and collapsed it into just a few. The patient's happy, and I've got to tell you, you've saved time and resources as well. So indeed, I would suggest there's a lot of really great key areas for patient portals to offer you efficiency and value in your practice that goes above and beyond meaningful use and the stage 2 proposed rules. Indeed, portals can allow your patients to communicate with you securely, offering the ability for you to document that communication, of course, critical in today's litigious environment. Portals can take a test result that's often provided verbally over the phone. And I've got to tell you, even though we try, it's commonly completely devoid of context. It's, okay, Ms. Woodcock, your cholesterol is blah, blah, blah. And what we can do is we can translate that into a meaningful presentation of not only the current data regarding test results, we can also display that alongside, if applicable, of course, historical results. And what this does is it creates the context to increase the patient's knowledge, his or her knowledge base, and ideally empowering them to improve their care. As highlighted in the example that I just gave about the prescription renewal process, indeed, we've taken that no-cost employee, and we've created a win-win. We've gotten value for our patients, and indeed, we've improved the process on our end vastly in terms of both time and efficiency. Migrating the billing process. Well, I can't stand up here and say, this is your key to increased collections, but it is your key to communicating the patient's financial responsibility without paying the outrageous sums of money we do today to the United States Postal Service. Huge dividends, considering that the average provider spends an amazing approximate $8,000 a year on statements. Moving this function, e-statements, secure information about the patient's financial responsibility to a portal equates to significant cost savings. And I've got to tell you, gosh, $1 saved indeed is $1 earned. And your appointments, I would suggest much more than just scheduling. I hate to think about our schedulers as schedulers. Oh my gosh, our appointment schedulers, they really are directors of business development. Our directors of business development, our directors of sales. Because what are they doing? Of course, they're selling your provider's time, a critical role in the practice. And what we can do with indeed a portal is offer access to appointment requests, or perhaps even actual appointment making. But what this means is increasing access to our practice, today limited in most practices from, and this drives me batty, like 8:30 to noon, and then we got to turn our phones off at lunch, which is the very time, by the way, that your patients have the opportunity in their own workplaces to call you, and then we turn it back on from 1 to possibly 4:30, and that's a great practice. We really need to embrace the notion that this is our business development. Patient access to our schedule is the cornerstone to our practice. Increasing access, improving business development, one of the key aspects of a patient portal. So we've really talked a lot about a lot of different things. In summary, CMS, the government proposed Stage 2. It really ushers in a new world, a world in which we not only engage patients and families, but at least as proposed, from a meaningful use perspective, we expect our patients to act. To meet the government's proposed Stage 2 criteria, I would suggest to you that a patient portal is really the only practical, realistic vehicle to be successful. And I would also submit to you that now is the time. Now is the time to embrace technology that can enhance access and communications that your patients have with you, and to meet their expectations of, indeed, this changing world. A patient portal can not only help you prepare for the next stage, for Stage 2, and, I can't wait for us to talk about Stage 3 and see what that, indeed, is going to be. It's not only to help you prepare for the next stage of meaningful use, which is absolutely, of course, a noble cause, but perhaps more importantly, it can create value for your practice and your patients today. Your practice and your patients today. Well, Chris, that actually concludes our program, and I really look forward to responding to any questions we might have from our listeners about today's webinar content. Chris?
Great. Thanks a lot, Elizabeth, and thank you, everyone, for joining us today, and we hope you found the last hour both educational and really informative. I understand that some of you had some trouble with the audio early on, and we apologize for that, and just wanted to remind you all that slides from today's session, in addition to a handout on the proposed meaningful use stage 2 objectives and information about Intuit Health, are all available in the resource list widget at the bottom of the console, and that's the green button with the open folder. And again, shortly following today's broadcast, we'll have a recorded version of the webinar available to all attendees. So we'll open the floor to Q&A now, and we've got a bunch of great questions coming in. Again, if you need to log off before we're done, we ask that you take a few minutes to complete the survey. As I said earlier, the survey after our June webinar led us to the topic for today's webinar, so we really do appreciate the feedback, and that'll help us improve kind of our schedule as we do webinars every quarter or so. Once again, if you haven't submitted a question yet, it's really simple. Type your question into the Q&A box on the screen and hit the submit button. And again, if we don't get to your questions in the next 15 minutes or so, we'll follow up with you individually. So our first question comes from Caroline, and it's to avoid penalties, can we just participate for the first year and then forget about meaningful use, or do we have to keep going?
Great question, Caroline, and certainly when I first heard about meaningful use in 2009, and I thought, okay, this is good, we've got some incentives, but a professional can go out there and indeed just be meaningful user for 1 year. But actually, I was completely wrong. Indeed, you can't just participate for the first year. In fact, in the Federal Register that we've really been discussing in today's webinar, the government makes it very clear that indeed you can't just participate and be successful in 2011 and 2012 in order to avoid the penalties for 2015, which is the first year that we'll see the penalties come into play. You have to be a successful, meaningful user in 2013 and on from there. There's also two very important points that I wanted to make clear. Number one is we know that, and I mentioned, hospital-based eligible professionals are indeed ineligible for this program, but in the Federal Register, the government states that hospital-based status will be reassessed each year. So don't just think about, all right, Caroline, I've got hospital-based status in 2013, I'm going to be good to go. Know that it's going to be reassessed. Furthermore, for those of you who are participating in the Medicaid program, you know that you don't even have to comply with meaningful use for the first year. In fact, you simply need to be adopting, implementing, or upgrading. But what the government does in the Federal Register is says, whoa, 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 adopting, implementing, or upgrading does not constitute the meaningful use of certified EHR technology. So those eligible professionals who receive the incentive payment for simply AI or Ewing actually are not going to be considered meaningful EHR users and will be subject to the Medicare reimbursement penalties. So really wanted to offer those important clarifications that we saw in the March Federal Register that's really been the subject of our program. Chris?
Okay, great. Thank you. The next question comes in from, there's a lot of questions around the 10%. So I kind of consolidated a few questions into one big question. So there was just some confusion, or if you can provide some clarity around, is it the 10% of patients who have access to the portal, or just those who are provided access, and is it just Medicare patients, or is it all patients, and what's the best way for a provider to keep track and document this percentage usage so they can qualify?
Okay, great. So when we talk about the 10%, now I believe that our listeners are referring to our criteria that we discussed, providing patients the ability to view online, download, and transmit the health information within 4 business days of that information being available to the professional. And that we actually, our measure, and this is part B of that 2-part measure, is that more than 10% of all patients seen actually do this, view, download, or transmit. Now, importantly, this is the real departure from stage 1, Chris, in that what we have here is the government telling us that this is not a provision. This is actually a patient action. More than 10% of our patients have to view, download, or transmit to a third party their health information. And this is where CMS has said, we realize this is a departure from stage 1. This is a totally new frontier. But what we have here is we're measuring the fact that your patients have acted. That's how serious we are about wanting you to extend this functionality to your patients. Now, the same thing that we talked about with regard to the secure messages, because that is also that 10% mark that our listeners may have been referring to, is not just good enough that we make the electronic messaging function available to 10% of our patients, but indeed, and remember, I said, oh my gosh, hello, we're actually indeed saying 10% of our patients must send us the message. Now, there was a couple of other segments of your question, Chris. I wrote down, is this for Medicare patients or everybody? Now, unlike the Physician Quality Reporting System, unlike Medicare's ERX program, the Electronic Health Record Incentive Program is for all patients, Chris. So I'm talking about Cigna, Aetna, United, Medicaid, Medicare, workers' comp, everyone, self-pay. So no, we're not just talking about Medicare patients. And furthermore, the Part C of your question indeed asks, okay, how are we going to document this? I'm really going to take us back to the comments that I made about this, like separate but aligned Federal Register that the government agency, if you recall that I mentioned the Office of the National Coordinator for Healthcare Information Technology, they released a Federal Register on the very same day that CMS released this one that we've been talking about with regard to meaningful use. So this separate Federal Register is really gearing vendors up to say, okay, how are we going to give all of these professionals the ability to carry out stage 2 criteria? And really therein lies the answer, Chris, in that your vendor, your system is really going to have to deliver you. If it retains its certification, it is going to have to deliver you the capacity to document and prove the 10% measure. Chris?
Okay, great. Thank you. A few other questions came in around the time frame for reporting meaningful use, and we have a specific one from Crystal. If we plan on a testing by the end of 2012 for the first time, can we use the changes that were talked about in stage 1, or do we have to wait until 2013?
Well, none of the changes that we're talking about relate to 2012. So I would certainly not recommend, for example, dropping that criteria, the capability to exchange clinical health information. Everything that we've discussed, the very earliest that we're going to be able to do this is indeed 2013. Now, we also want to remind you that this is the proposed criteria. So we'll certainly see some changes as we've had in the past, although I would suggest they're material, but they're not really kind of off the mark. So we know the government's trajectory here. We're probably not going to see a huge deviation from that, but just to make sure our listeners recognize is these are proposed rules, and we're going to need to wait until July to really definitively see what the final regulation says. So I most certainly wouldn't wait if I'm attesting in 2012 until July, particularly knowing that these changes are going to be effective as proposed in 2013.
Okay, great. Next question comes in from Tiffany. If I started meaningful use in 2011, will I still be able to receive a stimulus payment for using EMR in 2013?
So certainly, if you are a successful participant in meaningful use in 2011, and just to kind of review, the time frame for reporting meaningful use is actually 90 days in your first year, 90 days in your first year for Medicare only. As I mentioned, for Medicaid, you actually don't even have to attest to meaningful use in your first year. So if I can take my attendee down the Medicare track and say, all right, in 2011, you were successful with that 90-day period, then I would suggest in 2012, you are indeed going to be in the middle of a 365-day attestation period, as you will in 2013. For Medicare, this is actually going to be a 5-year payment program. Those payments do add up to $44,000. To respond to your question, for Medicare, you will indeed, in your third year, which would be 2013 as you ask, be eligible to receive that incentive. Now, if I can take our listener down the Medicaid track, in 2011, if your state allowed you to attest, some of them did not open in 2011, many waited until this year. If your state allowed you to attest, you simply needed, in order to get the first of a 6-year bonus program, to have proven adoption, implementation, or upgrading to meaningful use certified EHR system. In your second year, you indeed have the 90 days, and in your third year, the 365 days. But I think regardless, in 2013, depending on the track that you chose, you certainly would be eligible for that incentive payment if you are a successful attester. Chris?
Okay, great. Thank you. Next one comes from Amanda. If I haven't done an attestation for Medicare yet, can I still attest for stage 1, or do I need to wait until stage 2?
Now, you certainly can attest to stage 1, and I would strongly suggest that you do so in order to receive the highest amount, the maximum amount of the incentive payment, the $44,000. You do have until the end of this year to attest, and technically the government is giving you until the end of February for you to turn your attestation in related to 2012. So again, for our listener, you would want to go ahead and jump on board with stage 1. If you look at the actual schedule, even if you wait a couple of years, the government's still going to ask you to go to stage 1 first as kind of your basis, your kind of baseline, if you will. But Chris, we've got to remind our listeners that this is the final year for the Medicare program for you to receive the maximum incentive. I would strongly suggest not waiting until October 1st, that very last 90 days, but go ahead and get geared up to begin the process in June or July of this year to make sure that you're not waiting to the very last minute and realizing, oh my gosh, in measure number 13, I missed it by one patient. So if you're going to attest, you certainly want to look at stage 1. And you're going to look at stage 1 regardless of when you jump in. But please do recognize that 2012 is our final year in Medicare to receive the maximum payment. And that payment indeed is $44,000 per eligible professional. Chris?
Okay, I think we have time for one more question, and this question may have come in early in the presentation before you talked about the benefits of the portal, but the question specifically is around the patient experience, and how does this improve the patient experience as opposed to helping the doctors qualify for meaningful use?
I really think that access is our key term here. I believe that in our personal and professional lives that we've indeed had an entire new world open up to us in really the last 10 years. I mean, our cell phones, our Facebook accounts, we're used to a very instantaneous environment. And it always feels to me, and I'm a mother of 3 young children, I'm one of your frequent flyers, I'm in a medical practice, almost every single week, and it almost feels to me that we kind of have to step back and like almost come into our different world, and we put on our checklist, oh my gosh, I've got to remember to call for my 4-year-old's immunization form, because I got to remember to call between 8:30 and 11:30 and 1:30 and 4:30, and I've got to remember that I can't just have it sent to me immediately. Oh, I got 3 or 4 days. I got to drive back over there, have it in the mail. It's like we're almost living in two different worlds, our personal and professional world and then our healthcare world. And what I'm suggesting is that a portal really helps us from the patient's perspective to merge those two worlds, to create that access. And what I would strongly say is, don't look at all of these options and say, oh my gosh, this is too overwhelming. I don't know what my patients would do. They have appointments, prescriptions. See if you can put out one functionality, 2 functionalities, and really extend that. Or an even better idea, love for every practice that I work with to have a patient advisory group. And this is 6 or 8 patients that really are there to give you feedback about different aspects of your practice. Oh my gosh, a portal is the greatest thing to put on your next agenda. Ask your patients, what do you think about this? Would you use it? What kind of functions would you enjoy using? So instead of us kind of surmising what's value to the patient, let's go ahead and really listen to the voice of the customer. Chris, it's certainly been a pleasure to be a presenter for Intuit Health today, and I really want to thank everyone for their investment of time and hope that you've gotten a great overview of the Stage 2 proposed meaningful use criteria. Chris?
Okay. Thanks so much, Elizabeth, and everybody, thank you for all your great questions. There was a few we did not get to, and we'll be sure to follow up with each of you so you get the answers to your questions. And again, remember, following the broadcast, you'll receive an email to the address that you used to register for the webinar, and that'll have a link to the recorded version of today's session. So, and again, if you'd like to learn more about the Intuit Health Patient Portal, you can visit intuithealth.com or contact us at 877-599-5123. So that concludes today's presentation, and remember to please take the survey on your way out. And thank you to the folks at On24 for helping us host today's webinar. And on behalf of Elizabeth and Intuit Health, we really hope you enjoyed today's webinar. And again, let us know how we can do better by taking the survey. Thank you so much, and everyone enjoy the rest of your day.